Okay, a very good morning to all of you. Am I audible?
Yes, sir.
Okay, so in the last class, we have discussed about chloroquine and the classification of antimalarial drugs. So the mechanism of action of chloroquine, you know that it acts by inhibiting the heme polymerase enzyme, right? Can someone tell me few of the adverse effects of chloroquine? Important adverse effects that you see with chloroquine? Mr. Walid, roll number 118.
Yes, sir.
Okay, tell me few of the adverse effects of chloroquine.
Adverse effect cardiac depression.
Very good. Cardiac depression. But before that, you should tell the common adverse effects which are seen when we use it for malaria. Like the more common ones are related to the gastrointestinal tract, nausea, vomiting, right?
Nausea, vomiting. Yes, sir.
That is the gastrointestinal adverse effects. Then on long-term use, you may see the other adverse effects like cardiac depressant effect, right? Any
Yes,
other?
sir.
Because of its cumulative effect, it gets deposited in the retina. So any adverse effect you can see related to retina?
Ocular toxicity, sir.
Ocular toxicity, that is retinopathy, also known as
Bullseye.
bullseye retinopathy. Very good.
Rheumatoid arthritis.
It is when it is used in rheumatoid arthritis for long term. Okay, so visual defects can be seen, and lenticular opacities, cataract, that is also adverse effect of chloroquine. Also the graying of hair because of the bleaching, right? When it is given intravenously, there can be hypotension or the T wave changes in the ECG. Uses of chloroquine. Chloroquine can be used in chloroquine sensitive malaria, giardiasis, but in giardiasis it is not the first line drug. The other uses, lepra reaction, right? Rheumatoid arthritis, extraintestinal amoebiasis, infectious mononucleosis, and photogenic reactions. You can remember it by the mnemonic which I told you, my red lips. So now we proceed to the other antimalarial drugs. Okay. In the classification, we had seen that the antimalarial drugs, they are quinolines like 4 amino quinolines, 8 amino quinolines, or quinoline methanol. So 4 amino quinolines, we have chloroquine, hydroxychloroquine. Hydroxychloroquine is preferred in treatment of rheumatoid arthritis because it is less toxic than chloroquine when it is used for long term. Okay. Then the another 4 amino quinoline which we have is amodiaquine. So just the salient features now I will tell of the remaining anti-malarial drugs so that you can compare it with chloroquine. So amodiaquine is just as chloroquine. It is effective in even the chloroquine resistant malaria, and the pharmacological actions, they are similar to chloroquine. Adverse effect of amodiaquine, remember that amodiaquine is not used for prophylaxis of malaria for long term because of two important adverse effects. What are those two important adverse effects? One is a granulocytosis, okay, and second is hepatotoxicity. So these are the serious adverse effects of amodiaquine, and they generally occur when amodiaquine is used for long term, and that is why it is not recommended for prophylaxis. Agranulocytosis can occur in 1 in 2000 patients. Okay. Amodiaquine, the most common adverse effect is itching, but it is less than chloroquine. One important thing about amodiaquine is not given as a single drug, okay, because of the chances of resistance. It is always combined with artesunate. So artesunate is a artemisinin compound which is combined with amodiaquine. Okay, artesunate, its dose is 100 milligram twice daily, and amodiaquine, its dose is 600 milligram daily. Okay, 600 milligram daily given as 300 milligram twice daily. Okay, so the fixed dose combination of amodiaquine with artesunate is available, and that is used in uncomplicated falciparum malaria. Now piperaquine, it is used since 1978 in China in place of chloroquine. This piperaquine is high efficacy, and it has a long duration of action because of its half-life, that is 3 to 4 weeks. And it is also not used as a single drug. It is combined with dihydroartemisinin. So we have dihydroartemisinin 120 milligram. Along with that, piperaquine 960 milligram is given. Okay, so the ratio is 8 is to 1. And it is very effective in chloroquine resistant falciparum malaria. And important thing about this piperaquine is it is well tolerated in children, and in children the per kg dose is more, that is 20 milligram per kg dose is there in children in comparison to the adults, because children, they tolerate this piperaquine well. Now coming to mefloquine. Mefloquine is a quinoline methanol. Okay, all these drugs, they have mechanism of action similar to chloroquine. So mefloquine also, its mechanism is similar to chloroquine, and just like chloroquine, it is a rapidly acting erythrocytic schizonticide, but it has slow action than chloroquine and quinine. Mefloquine, it is also a drug which has a long half-life, okay, that is 2 to 3 weeks, and it undergoes enterohepatic circulation. It has a high plasma protein binding. It undergoes enterohepatic circulation. That is why it has a very long half-life, that is 2 to 3 weeks. And mefloquine generally is used for uncomplicated falciparum malaria, and also it can be used for prophylaxis of malaria when a patient is going to an endemic area where there is falciparum malaria, but it is not used for the patients who are residing in the endemic area, because again it cannot be given for a very long period of time. Now the important thing about mefloquine is its adverse effect. Okay, it has a lot of adverse effects, and the most important ones are the neuropsychiatric adverse effects. Like the neuropsychiatric adverse effects, like it can cause anxiety, hallucinations, sleep disturbances, and it can cause dizziness or ataxia, disturbed positional sense, and also it can cause difficulties in operating the machinery. So when a patient is given mefloquine, you should advise that he should not operate the machinery and he should not drive. Okay, so neuropsychiatric adverse effects, they are very important with mefloquine, and mefloquine is avoided in the first trimester because of the risk of teratogenicity. Also it is having cardiac adverse effects like bradycardia and QT prolongation. So the drugs like chloroquine, haloperidol, they should not be given along with mefloquine because of the added cardiac depressant action. More common adverse effects, just like chloroquine: nausea, vomiting, abdominal pain, diarrhea, right? But important adverse effect is neuropsychiatric disturbances. Uses of mefloquine: it is an effective drug for multi-drug resistant falciparum malaria, but again mefloquine is not given as a single drug. Okay, it is always combined with artesunate. So artesunate 100 milligram BD is given for 3 days, and along with that you give mefloquine 750 milligram on day 2 and 500 milligram on day 3. So just 2 doses of mefloquine, they are sufficient for the treatment of uncomplicated falciparum malaria along with artesunate. Also, it is used for prophylaxis in multi-drug resistant areas. Okay, it is not used for the endemic population which is staying in the endemic area. It is used for the travelers like the Western people, or if someone from US is going to Africa where there is endemic MDR malaria. So he will be given mefloquine 250 milligram every week, and it should be started 2 to 3 weeks before. Why it should be started 2 to 3 weeks before? So that you come to know about the adverse effects. Okay, if the patient is having adverse effects, you change the drug. Okay, and also 1 week before, so as to achieve the target concentration. Okay, so these things should be taken care of, and due to the fear of development of resistance, it is not used in the patients of endemic area. So we have seen amodiaquine. Amodiaquine is just like chloroquine, but used in chloroquine-resistant malaria, right? Important adverse effect of amodiaquine: agranulocytosis. Second, we have seen piperaquine, and important thing about piperaquine, it is combined with dihydroartemisinin, right? Also used in chloroquine-resistant falciparum malaria. The third drug which we have seen was mefloquine, right? Mefloquine, important adverse effects are the neuropsychiatric ones. Now coming to quinine. Quinine is an age-old drug. It is actually the oldest drug which was used for the treatment of malaria. It was synthesized in 1820 by Pelletier and Caventou, and it is an alkaloid which is obtained from cinchona bark. Mechanism of action: it is similar to chloroquine. It is antimalarial, and it is having the effect against all erythrocytic forms, that is erythrocytic schizogony, including Plasmodium falciparum. Also, it is having gametocidal activity against vivax and malaria. It is not having gametocidal activity against the falciparum malaria. Now, the other actions of quinine. Quinine is a local irritant. Okay, so when you are giving it intravenously, take care that it does not leak out, because it will lead to necrosis, and then the other complications because of its necrosis, gangrene, fibrosis, etc. Okay, so it should not leak out, and it is not given by intramuscular route because of its irritant action. It increases the gastric acid secretion when it is given orally. Okay, it is also a cardiac depressant. Uh, the the drug quinidine, okay, it is the L isomer of quinine, and it is more cardiac depressant than quinine. That is why quinidine is also used as a antiarrhythmic drug. Quinine is having analgesic action, antipyretic action, and skeletal muscle relaxant action. Also, it is a uterine stimulant, so it can cause the abortion in the early phase, but it is not used for all these purposes except for myotonia congenita and nocturnal muscle cramps. Uses of quinine. Quinine is not used for routine malaria, that is chloroquine sensitive. Okay, it is used only when there is chloroquine resistance. And now also nowadays it is not preferred because we have better drugs like artemisinin group of drugs, artesunate, artemether, arteether, right? So it is a reserved drug now which is used when we cannot use the other artemisinin drugs. It is used in myotonia congenita mainly because of its curar mimetic effect, because it causes skeletal muscle relaxation, nocturnal muscle cramps because of the same reason, because of its local irritant action. It can be used as a spermicidal. It was used previously in some of the vaginal creams, and varicose veins. It was used along with urethane because of its irritant action. Now coming to the adverse effects of quinine. Generally, when quinine is given, quinine does not have uh, adverse effects when it is given in therapeutic doses. Okay, it has very minimal adverse effects, which are gastrointestinal or headache or dizziness. But when it is given uh, in high doses, okay, when it is given in high doses, it can cause synchronism. Okay, a single high dose, or when it is given for long term, then it can cause an adverse effect known as synchronism. So how does a patient of synchronism present? Okay, a patient of synchronism who is on quinine will present to you with headache. Okay, he will be having headache, and he will complain of tinnitus, that is ringing in the ears. He will have some visual defects. He will have some auditory defects. Okay, also diarrhea. So these are the symptoms of synchronism. Synchronism is seen in high doses. Quinine is a very toxic drug. Okay, the toxic dose of quinine is 10 to 20 grams. If you give 10 to 20 grams of quinine, the patient may die. The second adverse effect is cardiotoxicity. Okay, synchronism, if you stop quinine over a period of 2 to 3 weeks, the adverse effects of this synchronism may go off. Second is cardiotoxicity because of its cardiac depressant effect. It can cause hypotension. Okay, so hypotension is very common, and it should be taken care when we are giving quinine intravenously for the treatment of severe falciparum malaria. Then black water fever. Okay, black water fever is a complication of severe falciparum malaria, where there is a triad of hemolysis. Okay, there is hemolysis, because of which there is hemoglobinemia, that is the hemoglobin is decreased, and there is hematuria. Okay, so because of this hematuria, the color of urine is black, and that is why it is known as black water fever. So black water fever can occur when we are giving quinine, and hypoglycemia occurs with quinine because of release of insulin. Okay, so whenever we are giving quinine intravenously, what precaution we are taking? We are giving quinine with dextrose 5% or dextrose normal saline. Okay, the dose of quinine is 20 milligram per kg initial dose. So it is given along with 10 milligram per kg of dextrose 5%. So this 600 milligram of quinine can be dissolved in 500 ml of dextrose 5% and given over a period of 4 hours initially. Then the dose is reduced to 10 milligram per kg every 8 hourly till the patient can take oral drugs. Okay, so these are the adverse effects of quinine. Synchronism. Okay, synchronism because it is obtained from cinchona bark. Okay, that the main symptom of synchronism is ringing in the ears. So if the patient comes to you with ringing in the ears and is on quinine, stop quinine. Now coming to primaquine. So this primaquine, the mechanism of action of primaquine, the intermediate metabolites which are formed of primaquine in the liver, they generate the toxic oxidative species or reactive oxygen species. And this toxic oxygen oxidative species, they disrupt the electron transport in the plasmodial mitochondria. Okay, primaquine is especially useful in exoerythrocytic stage of or hypnozoids of vivax and oval. Okay, and also it is useful for the erythrocytic stage of vivax, but it is a weak erythrocytic schizont for the suppressive action. It has no action against the erythrocytic stage of falciparum. So the most important thing about primaquine is first a hypnozoidal drug for vivax and oval, and second is it is the best gametocidal drug. It is effective against the gametocytes of all the 4 malarial species. Okay. So what are the adverse effects of primaquine? Primaquine, the most important adverse effect is yes, any problem? So most important adverse effect of primaquine is hemolysis in case of G6PD deficiency. Okay, we have already seen the drugs which can cause hemolysis in G6PD deficiency. One we have seen when we were discussing leprosy, that is dapsone, right? Also there are this nitrofurantoin. Okay, and then we have seen this drug, that is primaquine. So primaquine, it can cause mild anemia, methemoglobinemia, and hemolytic anemia in G6PD deficiency. It should be avoided in pregnancy because the fetus is G6PD deficient. What is the use of primaquine? Primaquine is used for radical cure of malaria. You know, radical cure means complete eradication of the malarial parasites in case of vivax and oval malaria. So after chloroquine, you give primaquine in the dose of 15 milligram for 14 days, right? In case of falciparum malaria, you give a single dose of 45 milligram. Why it is given? To kill the gametes and cut the transmission of malaria. Now this primaquine should be given daily for about 14 days. Okay, so compliance may be a problem. That is why these 2 new drugs are important, that is tefenaquine and bulaquine. Tefenaquine, it is having a very long half-life and it can be given on a weekly basis. 800 milligram can be given, and This bulaquine, it is a drug which was synthesized in India for radical cure of vivax and oval malaria. It is given in the dose of 25 milligram for 5 days. So the duration of therapy reduces from 14 days to 5 days when we are using bulaquine. Coming to atovaquone, again, atovaquone is a very good drug for falciparum malaria. It is a rapidly acting erythrocytic schizontecide for Plasmodium falciparum and also the other Plasmodia. Mechanism of action of atovaquone, it collapses the mitochondrial membrane, okay, and interferes with ATP synthesis in the Plasmodia. Atovaquone is always used in combination with proguanil. Okay, it is not used alone. Why it is combined with proguanil? Because proguanil, it potentiates the action of atovaquone and it prevents the development of resistance. So this malarone, it is the fixed dose combination of atovaquone with proguanil, and 4 tablets daily for 3 days. That is atovaquone and proguanil combination, 250 plus 100 milligram. It is used for the treatment of uncomplicated falciparum malaria. Now, in the classification of anti-malarial drugs, we had seen that there are quinolines like 4-aminoquinoline, 8-aminoquinoline, quinoline, methanol, then naftoquinone derivative, that is atovaquone, then primaquine, and then there were the antimicrobial drugs. So in antimicrobial drugs, you had sulfonamides like sulfadoxine, then pyrimethamine, and dapsone tetracyclines. Okay, so there was a question asked in last class why we use sulfonamides. Okay, we use sulfonamide. Sulfonamide as such, it has a very weak antimalarial action. Okay, or maybe negligible antimalarial action, but still it is combined with pyrimethamine. Sulfadoxine, it is the longest acting sulfonamide. Okay, and it is combined with pyrimethamine because this sulfadoxine, it potentiates the action of pyrimethamine. This is an example of supra-additive action, just like sulfamethoxazole and trimethoprim. Individual drugs, they are bacteriostatic. When we use in combination, it is bactericidal, and it is the example of potentiation. So similarly, we are using sulfadoxine. We are combining it with pyrimethamine because there is a sequential blockade. Okay, two enzymes in sequence, they are blocked. One enzyme, this dihydrofolate synthetase, is blocked by sulfadoxine. Okay, and the second enzyme, that is dihydrofolate reductase, is inhibited by pyrimethamine and proguanil. Okay, so these two enzymes in sequence in the plasmodium, they are inhibited. So the plasmodium, it will not be able to synthesize its own folic acid. It and that will lead to the defect in the DNA synthesis in the plasmodium. Okay, so this is an example of sequential blockade. This is the example of supra-additive action. Pyrimethamine, it is tasteless and so suitable in children. Always it is combined with sulfadoxine. So pyrimethamine, 75 milligram, it is always combined with sulfadoxine, 1500 milligram. Okay, and this dose, a single dose, is sufficient for treatment of uncomplicated falciparum malaria. This sulfadoxine pyrimethamine is combined with artesunate in artemisinin based combination therapy, and this is used as the first line anti-malarial drug for uncomplicated falciparum malaria under the national malaria program, that is national vector-borne diseases control program. The first line drug which we use for uncomplicated falciparum malaria is artesunate and a single dose of sulfadoxine and pyrimethamine. So adverse effects of all the folate inhibitors, right, which inhibit the dihydrofolate reductase. What is the main adverse effect? They can cause folate deficiency. That's why they can cause megaloblastic anemia. Sulfonamides and pyrimethamine, they can cause thrombocytopenia and agranulocytosis. When we were dealing with sulfonamides, you must have heard about the adverse effects of sulfonamide, that is Stevenson-Johnson syndrome, rashes. Okay, they are also very common. So you should keep this in mind. Uh, the reactions or adverse effects that occur with sulfonamides and pyrimethamine. So why pyrimethamine is not used for prophylaxis? Because of the adverse effect of Stevenson-Johnson syndrome or severe cutaneous reactions. Proguanil, it is a prodrug converted to cycloguanil, which is having the action of inhibiting the dihydrofolate reductase. Adverse effects similar to pyrimethamine, that is megaloblastic anemia. Now coming to halofanthrin, this halofanthrin, it is not used nowadays because of its erratic bioavailability and lethal cardiotoxicity. But its congener, that is lumefantrine. Okay, lumefantrine is a newer congener of halofanthrin, which is used for the treatment of falciparum malaria, and it is combined with artemether. So artemether plus lumefantrine is used, but halofanthrin is not preferred nowadays. Okay, so this was about the other drugs used in the treatment of malaria. Okay, first we have seen chloroquine, the use of chloroquine. First is the malaria, right? Which malaria? Chloroquine sensitive malaria. Okay, and in chloroquine resistant malaria or falciparum malaria, all the other drugs which we have seen are used except primaquine. Primaquine and proguanil, they are used only for causal prophylaxis, and they are used for radical cure of malaria. For radical cure of malaria, you use primaquine. Now coming to the most important drugs, okay, the drugs which have changed the scenario of malaria, which have reduced the incidence of malaria, decreased the recurrence rate. So they are the artemisinin derivatives. Okay, so artemisinin derivatives, all the artemisinin derivatives, they are obtained from this plant. This is known as Artemisia annua. Okay, Artemisia annua, also known as Qing Hao Su in Chinese. Okay, so it is sweet wormwood plant, and from this all the artemisinin derivatives, they were synthesized. So what are these artemisinin derivatives? First is artesunate. Artesunate is soluble in water, and it can be given by IV, intramuscular or oral route. Artemether, it is soluble in oil, and it is given by intramuscular and oral route. Dihydroartemisinin, it is given by oral route, and arteether, it is given by oral route. So these are the artemisinin derivatives. We have one more artemisinin derivative which was synthesized in India, that is arterolone. Okay, now this dihydroartemisinin, it is the intermediate metabolite of artesunate and artemether. So artesunate and artemether, they are converted to dihydroartemisinin in the body, and also we have dihydroartemisinin as a drug which can be used in therapy. So mechanism of action of this artemisinin compounds, all these artemisinin compounds, they have a presence of endoperoxide bridge. So this is a OO bond or a endo-peroxide bridge. This endo-peroxide bridge, it can interact with the heme parasite. Okay, the heme iron, it is cleaved and by the parasite, and this leads to the generation of free radicals. These free radicals, they can damage to the parasite membrane. What these free radicals do, they can cause lipid peroxidation. Okay, they cause lipid peroxidation. Then they can destroy the endoplasmic reticulum, and ultimately they can cause lysis of the plasmodium parasites. Okay, a recent mechanism which has been found out, it is that they inhibit calcium ATPase. Okay, calcium ATPase of the sarcoplasmic reticulum of the plasmodium is inhibited. It is known as PF-ATP6. So this PF-ATP6 calcium ATPase is inhibited by artemisinin compounds. Why these artemisinin compounds are so important? Because they are the fastest acting drugs. Okay, they are fastest acting drugs. They improve the symptoms within 24 to 48 hours. They cause rapid clearance of the parasite from the body, and the resistance to these drugs has not been seen yet, or if even if it is seen, it is very negligible. So that is why these drugs are very important. Antimalarial action, it is effective mainly against the erythrocytic schizogony stage. They are not effective against the pre-erythrocytic or hypnozoites, and they are also effective against the early forms of gametocytes. So artesunate, it can be given by oral route, intramuscular route, or IV route. Its dose is 100 milligram twice daily for 3 days when it is given in combination as artemisinin based combination therapy. Okay, artesunate is combined with other drugs which we have seen, like it can be combined with, yes, artesunate can be combined with which drug we can combine artesunate? We have already seen this. Sulfadoxin, pyrimethamine. Okay, it can be combined with mefloquine. It can be combined with amodiaquine. Okay, this is known as artemisinin based combination therapy. So when we are combining artesunate with other drugs, artesunate is given for 3 days, and WHO does not recommend that this artemisinin compound should be given as a single drug. Why? Because they should be given for a period of 5 to 7 days. Okay, to prevent the recrudescence. What is recrudescence? One thing is relapse, right? What is relapse? Relapse is because of hypnozoites and seen only in cases of vivax and oval malaria. Recrudescence is seen because of incomplete treatment. Okay, the tropozoite form or the merozoites, they will remain in the circulation, they will not be killed properly, and that will lead to recrudescence. So to prevent the recrudescence in Plasmodium falciparum malariae, what you should do, you should give the artemisinin compounds for a period of minimum 5 to 7 days. And if we give it for a long period of time, there are chances of resistance. That is why we combine this artemisinin compounds with the other drugs, and it is known as artemisinin based combination therapy. Artesunate can be given intravenously in the dose of 2.4 milligram per kg. It is used intravenously in cases of severe falciparum malaria. So advantages of artemisinin compounds are artesunate, substantial reduction of the parasite biomass. About 95% of the parasites, they are killed when we use it for 3 days. And the symptoms, they resolve in 1 to 3 days. Okay, it is effective for multi-drug resistant falciparum malaria. Also, there is reduction in the gametocytes and no documented parasite resistance. And also the adverse effects of artemisinin compounds, they are less in comparison to quinine, which was the option previously for treatment of falciparum malaria. So artemether, its dose is 80 milligram twice daily, and this artemether is combined with lumefantrine. Okay, always it is combined with lumefantrine. It is not given alone. So 80 milligrams of artemether given along with 80 milligrams of lumefantrine, and it is given twice daily. Arte ether is given in the dose of 150 milligram intramuscular for 3 days, and it is given as a single drug for treatment of severe falciparum malaria. It is equivalent to quinine. Now, what are the adverse effects of artemisinin compounds like artesunate, arteether, and artemether? The adverse effects, they are very minimal, and the patients, they tolerate this artemisinin compounds very well. The adverse effects are nausea, vomiting, abdominal pain, which are common. The rare ones, leukopenia, reticulocytopenia can be seen. Also hypersensitivity reaction and abnormal bleeding and dark urine, very rare. Okay, they are the rare adverse effects. More common ones are nausea, vomiting, and abdominal pain. So you can see over here the adverse effects of the artemisinin compounds. They are less severe than that of quinine. Quinine can cause hypoglycemia, it can cause hypotension, it can cause synchronism, it is toxic, it can cause cardiotoxicity, right? That is why you prefer artemisinin compounds for the treatment of falciparum malaria as well as severe falciparum malaria. Sometimes in your exam, you are asked a question or a short note on artemisinin based combination therapy. Okay. So what is artemisinin based combination therapy? Artemisinin based combination therapy means you are using a artemisinin compound like artesunate, artemether, or arteether, and you are combining it with some other drug, right?
Lumefantrine.
Yes. So why we have to combine it with some other drug? Because artemisinin compounds are shorter acting. Okay, they have a short half-life, and the monotherapy with artemisinin should be extended beyond the period of the disappearance of parasite. Okay, to prevent the recrudescence. That is, it should be given for minimum period of 5 to 7 days. But when we are combining it with a long-acting drug, okay, long-acting drug like mefloquine, the duration of therapy can be reduced from 5 to 7 days. The duration of therapy is reduced to just 3 days, and it is indicated by the World Health Organization in the treatment of uncomplicated falciparum malaria. So why combination therapy? Because it causes rapid clinical and parasitological cure, and there is low relapse rate. Actually, it is recrudescence. Okay, relapse is mainly for Vivax and Ovel, right? Absence of resistance and good tolerability profile, less adverse effects in comparison to quinine. So what are the ACT regimens which are used or which are approved by the WHO and which are used in India? So the first is artesunate along with sulfadoxine and pyrimethamine. Remember, the dose of artesunate always is 100 milligram twice daily. When it is given oral, it is 100 milligram twice daily for 3 days. And along with this, we are acting a longer acting drug, which is slow acting. So sulfadoxine, pyrimethamine. Sulfadoxine is 1500 milligram and pyrimethamine is 75 milligram. So the tablet of this sulfadoxine pyrimethamine, it is a fixed dose combination having 500 milligram of sulfadoxine and 25 milligram of pyrimethamine. This is one tablet. So such 3 tablets of sulfadoxine pyrimethamine should be taken as a single dose, okay, along with artesunate 100 milligram BD for 3 days. This is just a single dose of 3 tablets of sulfadoxine pyrimethamine. Second ACT is artesunate and mefloquine, but it is not preferred because because of the adverse effect of mefloquine. Which adverse effect? Neuropsychiatric adverse effects. Okay, that is why this combination is not so preferred in India. Artesunate 100 milligram BD for 3 days plus mefloquine 750 milligram on second day and 500 milligram on third day. Artemether with lumefantrine, that is 80 milligram of artemether, 480 milligram of lumefantrine, BD for 3 days. Now, one important thing when you are giving this artemether with lumefantrine, always give it with a fatty meal. Why? Because it increases the absorption of lumefantrine. Lumefantrine is lipid highly lipophilic and its absorption is increased when we are giving it along with a fatty food. Okay, you can give milk along with it. Okay, so uh, that is lumefantrine, and again this combination is available as a FDC. Other ACT regimens, artesunate with amodiaquine, dihydroartemisinin with piperaquine, and arterolone with piperaquine. Okay. Now you can be asked a question on ACT, that is artemisinin based combination therapy. Whenever it is asked, first thing you have to justify. First you have to define that it is the combination of artemisinin compounds with the other long acting drugs, right? Then you have to give the justification why we add artemisinin along with the other drugs. And third is you have to write at least 4 ACT regimens. Okay. And what is the use of ACT? ACT is used in uncomplicated falciparum malaria. Now coming to the management of malaria. Okay, how you manage the malaria. So at least after this class, you should be able to manage malaria. If it is chloroquine sensitive, what you will give? You will give chloroquine along with primaquine, right? Second type is uncomplicated falciparum, which is chloroquine resistant malaria but uncomplicated without any serious effect. And third is serious malaria or cerebral malaria. Also, you should know how to prevent malaria. Okay, there are various methods, right? But we will only discuss the chemoprophylaxis, how to use the drugs for the prevention of malaria. Okay, so prophylaxis of malaria, also known as chemoprophylaxis, it is indicated when a patient from non-endemic area is going to a endemic area, like a traveler is there, okay, or if there is a immuno compromised patient, okay, or pregnant female in an endemic area, or children, for them also you can give chemoprophylaxis. So chemoprophylaxis for malaria, you use chloroquine, mefloquine, doxycycline, or atowacone proguanil combination. Now, whenever you are giving these drugs, you should start 1 to 2 weeks before. Okay, always start 1 to 2 weeks before, so you come to know about the adverse effects of these drugs, and also in this 1 week there will be attainment of the steady state for preventing the parasitemia. So always start 1 to 2 weeks before, but for mefloquine we start 2 to 3 weeks before because we want to see its adverse effect, right? And it is continued till 1 month after the patient returns from the endemic area. Okay, so the whole stay of the patient, you will give this chemoprophylaxis, and again you will continue it 1 month after the patient returns from the endemic area. So chloroquine is given when he is going to an area where there is chloroquine sensitive malaria. The loading dose is given, that is 600 milligram 1 week before, and then when the patient goes to the endemic area he takes 300 milligram per week, because chloroquine is a cumulative drug, okay, and it has a long half life. Mefloquine, it is used only for travelers, not for endemic malaria, and 250 milligram once a week. Doxycycline is given 100 milligram daily, and atovaquone proguanil can be given daily, that is 250 milligram atovaquone and 100 milligram proguanil daily is used. Also clindamycin is used by some in cases of resistant malaria, okay, but these are the most important regimens. First is chloroquine, second is mefloquine, and third is doxycycline. So prophylaxis of malaria can be asked to you as a short note of 4 marks, that is chemoprophylaxis of malaria. You can write about causal prophylaxis also over here, that is causal prophylaxis by primaquine, proguanil, pyrimethamine, and chemoprophylaxis. Chemoprophylaxis mainly used for travelers and also can be used for pregnant ladies, infants, children, and immunocompromised patients. You should start 1 to 2 months, 1 to 2 weeks before, and continue 1 month after the patient returns from the endemic area. And remember the drugs which are given for prophylaxis of malaria. Now, drugs which are not used for prophylaxis, quinine and artemisinin compounds, because quinine is toxic. Artemisinin compounds, resistance can develop and we want to preserve them. Pyrimethamine and sulfadoxine not given because of the adverse effects, that is agranulocytosis and this allergic reactions, severe skin reaction like Stevenson-Johnson syndrome. Amodiaquone is not used because of its adverse effect, that is agranulocytosis and hepatotoxicity. Now, how to treat chloroquine sensitive malaria? Already we have seen in the previous class. Give chloroquine 600 milligram base of chloroquine stat, that is 4 tablets of chloroquine phosphate. Then after 8 hours you give 300 milligram, okay, and then 150 milligram you give BD for 2 days. So remember this regimen. Also you can use this in your prescription writing, because in prescription writing sometimes you may be asked about treatment of chloroquine sensitive malaria. And then you give primaquine for a period of 14 days. What is the dose? 15 milligram of primaquine. So this is given in cases of Vivax and Ovel, which are sensitive to chloroquine. And in case of falciparum, just a single dose of primaquine. Now, treatment of uncomplicated falciparum malaria, no need to repeat all the ACT combinations which we have seen previously. Okay, that is artesunate with sulfadoxine pyrimethamine, artesunate with mefloquine, artesunate with amodiaquine, artemether with lumefantrine, then dihydroartemisinin with piperaquine, and arterolone with piperaquine. So those ACT combinations are the treatment of uncomplicated falciparum malaria. So resistance should be suspected in all patients who have complication of malaria, like involvement of the CNS, cerebral malaria, or involvement of the kidneys or black water fever. So if there is a complication, suspect that there is resistance. And if there is relapse in a patient who has received chloroquine in the past 1 month, again resistance should be suspected. And if there is a fall in hemoglobin, continuous fall in hemoglobin in absence of bleeding, then suspect this resistant malaria. So severe and complicated malaria, this is out of the scope of this lecture, but still just to show you what is the definition of severe malaria. So if any of these things is present in case of malaria, then it is a severe malaria. That is hyperparasitemia, hyperparexia, hypoglycemia, cardiovascular collapse, etc. So for severe malaria, what is the treatment? The treatment of choice is intravenous artesunate, okay, given in the dose of 2.4 milligram per kg. Then it is followed by 2.4 milligram per kg after 12 and then 24 hours, and then daily for 7 days, or till the patient can take orally. If the patient can take orally, then you can start with oral artemisinin based combination therapy for 3 days. If you cannot use this artemisinin compounds, like in the first trimester of pregnancy, artemisinin compounds, they are contraindicated. Okay. So in a pregnant lady with severe falciparum malaria, you have to use quinine. Okay, so quinine is given in the dose of 20 milligram per kg, and it is diluted with dextrose, 5% dextrose. It is given along with this 5% dextrose or DNS, and it should be given slowly over the period of 4 hours, and then you give 10 milligram per kg maintenance dose every 8 hourly until the patient is conscious and he can take the drug orally. Now malaria in children, quinine, it should not be given because of high toxicity. Okay, the parenteral quinine, oral quinine can be tolerated well, but in children also you can give the artemisinin compounds, which are the first line for falciparum malaria. Primaquine avoid in neonates because of G6PD deficiency, and mefloquine should not be used in children less than 15 kg weight, again because of the adverse effects. In pregnant females, chloroquine can be used in usual doses in chloroquine sensitive malaria. Mefloquine and artemisinin compounds, they are contraindicated in first trimester of pregnancy. Then you should also avoid sulfadoxine, pyrimethamine, primaquine, tetracycline because of the teratogenicity. Okay, so this completes our anti-malarial drug therapy. The important questions which can be asked to you on anti-malarial drugs, this is a very important topic of national importance. Okay, anywhere you go in medicine or in community medicine or in pharmacology, always you will be asked questions in malaria or anti-malarial drugs. Okay, so you can expect a long question on anti-malarial drugs. Classify anti-malarial drugs. Okay, give the mechanism of action, uses, adverse effects of chloroquine, which is a very common question. If not chloroquine, then you can be asked about artemisinin compounds as a short bit of the long question, or you can be asked about quinine or mefloquine. Okay, so remember all these drugs like chloroquine, amodiaquine, quinine, mefloquine, they have a similar mechanism of action. Then you can be asked a short note on uses of chloroquine. Okay, because chloroquine is used in many other indications apart from malaria. So remember the uses of chloroquine. You can be asked a short note on adverse effects of chloroquine. Okay, Then a short note on mefloquine or any antimalarial drug. So remember the format is same: mechanism of action, adverse effects, relevant, pharmacokinetics. Okay. And artemisinin based compounds can be asked as a short note, or you can be asked artemisinin based combination therapy. Okay. A short note can be asked of 2 marks on why chloroquine is given as a loading dose. That is included in this slide, which you can go through. Also, you can be asked the rationale of artemisinin based combination therapy. Okay. And also, this is very important from the Viva point of view, right? Also, you have few prescriptions on uncomplicated falciparum malaria and chloroquine sensitive malaria. So overall, this is a very important topic, and maybe in the next class, whichever is there in the next month, in September, I will take a 50 marks MCQ test for you on antimalarials and immunosuppressant drugs, which I will deal with in the next class. If you have any query or doubt, you can ask, please. Okay, if there are no doubts, thank you very much. Stay safe from corona. Don't roam outside. Use all the precautions, right? Because day by day the cases are increasing. Thank you very much.